Okay, we are live. Good evening. Thank you so much for joining me. I am Sandra Samuels. I am a breast cancer survivor, and we are joining this evening to speak on breast cancer. I am a 22-year breast cancer survivor, and I'm reaching out to you from Jamaica Reach Recovery. We have some of our members with us. We have the chairman, Carolyn Graham, with us. We have a many-year survivor, and she'll speak to you shortly, Mrs. Gloria Ramsay. We have Latoya Jones, and we have Dr. Jason Copeland. We want to thank you so much for joining. As this, you know by now, by the amount of pink you have seen in the month of October, that this is Breast Cancer Awareness Month. And we are asking that you support all the breast cancer survivors by wearing pink this month. And Carolyn will just talk a little bit more about Breast Cancer Awareness Month and what we are doing for this month and how you can participate in this month. Welcome, Carolyn.
Thank you very much, Sandra. It's wonderful to be able to sit with people like us. We have been down this road and we have done the journey and we're fine.
Yes.
Breast cancer is something that tends to frighten people. But I hope that at the end of this, it's not as bad as they thought it would have been.
Tell us a little bit about yourself and your journey in about 10 minutes before you go into your role at Jamaica Reach to Recovery. And why did you choose to take up this role?
Okay, well, my journey was really very simple. From the age of 45, my gynecologist said, you do a mammogram every year. And I was very obedient. I did a mammogram every year. And my gynecologist was Dr. David Thwaites, who is our founder's husband. So 1 year, I normally do it about August each year. And in 2004, I did my normal mammogram. And they called me back and said they wanted me to come back in and do an ultrasound. So I went back and I did an ultrasound. And then they said, Dr. Thwaites called me and he said, well, they saw some little grains on the mammogram. And I said, something was wrong with the plate that they used. The film had dirt on it and they didn't know, because I knew that I didn't have breast cancer. There was nothing wrong with me. I had no problem, and there was something wrong with their equipment. I then said, do it again. And he said, okay, we'll do it again. So I went back down and I did another mammogram, and I had another dirty plate. It had the same little grains of sand on it. So at that point, I said, okay, let's be reasonable. If it had a problem in the first one, and it's the same thing in the second one, then maybe there's something here to look at. So he said, fine, go and do a biopsy. So I went and I did a biopsy. And I'll never forget this day. He called me and he said, come and see me. Bring your husband with you. Now, when a doctor says, come and see me, I don't normally want to see my doctor, and he shouldn't want to see me. So if he tells me, come and see me, then something not right here. So we both went in and we sat down, and he said, well, the tests have come back, and you are positive for breast cancer. And I looked at him, and I must confess, I went deaf because I heard nothing else. He was there talking, and I saw the mouth moving, and I was hearing nothing. So at the end of that, we got up and we left. And my husband's name is Ronnie, and he said to me, "You're okay?" And I said, "No, something is not right here. I didn't hear what he said. What did he say?"
Exactly.
And he said, "Well, he says we have a problem and we're going to work it out. We're going to solve the problem." So I said, "No, let me go back in." So I just said to the nurse, "Can I go back and see Dr. Swiss?" She says, "Yeah." So I went back in. And I said, "Okay, you're telling me I have breast cancer?" He said, "Yes." I said, "And what next?" He says, "Well, you can do I wouldn't suggest you do a lumpectomy because there's no lump. The only really thing you can do is do a mastectomy and we remove the breast." And I said, "When?" And he sort of looked at me like, "When?" "Yes,
Mhm.
when?" He said, "Okay, well, he'll speak with the surgeon and I can make an appointment." And that was the end of August. My
What year
appointment,
was that?
2004.
Mm-hmm.
My appointment, I went to see my surgeon who recently died, Dr. McFarlane. And he said, "Well, I can't do this until the 19th of October." And I said, "Fine." And then he said, "Did Dr. Thwaites say anything else to you?" So I said, "Yes, he told me something about a group of women who meet at Cancer Society and I should go and talk to them." He said, "Yes, that would be a good thing to do."
Mm-hmm.
So with that, and well, the cancer, you probably was at the meeting. I am a
Mm-hmm.
crier. I am
Yes.
a crier. Now, surgery was scheduled for the 19th of October. Reach to Recovery meets on the second Tuesday in the month. So I went to the meeting before I did surgery. And having known nobody who had had breast cancer,
Yes.
there was no history of breast cancer in my family. It was a totally new era of life for me. I went to this meeting not sure what I would see these women looking like. Would they look strange? If they have one breast, do they look twisted? Do they look
Mm-hmm.
funny? So you sort of went
Yes.
in there with
All of
great
those
strength.
thoughts go through your mind. Yeah.
And everybody looked normal. Nobody looked strange. So you sort of said, "Oh, so it can't be that bad." And
Mm-hmm.
I balled in the people's meeting. Went on quite bad. But it was, for me, an eye-opening experience to actually go and see women who had been through this experience and
For many
looked,
years.
yes, and they looked normal. I mean, I would have
Right.
passed them in the road and not knew anything was wrong with them or had been wrong with them.
Right.
So, armed with
So
that,
you
I did
joined.
my,
So you joined Reach to Recovery.
yes, that was my first meeting. And as soon as I was able to attend meetings, I attended meetings. Because for me, it was a source of real reassurance that there is life and a full life
Right.
after breast cancer.
Right.
And in terms of treatment, I didn't do chemo, so I can't relate very well to people who have done chemo. I didn't do radiotherapy, so I can't relate to that very well either. I was estrogen positive, so I was on tamoxifen for 5 years. And this is now 18 years down the road, and here I am.
Wonderful. So you would say that going to a group of ladies who have gone through the same thing, the support makes all the difference.
It does. It really, for me, it did. It was a
Right.
reassuring position to actually see what was possible because I had no point
I
of reference.
concur. I concur. So, okay, so what exactly does Reach to Recovery do now? And what are we doing for this month?
Well, Reach to Recovery is still in a recovery mode from COVID. We meet on the second Tuesday of every month. And before COVID, we used to have in attendance maybe 50, 60 with ladies. We then went virtual, so we were doing meetings by Zoom up until May this year. We have now resumed our face-to-face meetings. The attendance is like about maybe 30, 40 persons, but we know that those who come for them, we mean something and we are helping. What does Reach to Recovery do? We provide support for women who are on a journey of recovery from breast cancer. We see persons who come in, like I did before surgery, not knowing what is going on. We see others who have done surgery and are doing additional treatment, who are not sure if the reactions that they're having are abnormal, or is this what is to be expected. People lose their hair and they start saying, I feel so embarrassed, I can't go out because I'm now bald. It's a case of almost whatever you can find is happening with you, there is somebody in the group who can relate to it, who
Right.
can say, yes, this has happened, or yes, I had the same challenge. This is how we handle it. It will pass, or this is how you do to overcome that particular thing. So we
Right.
provide peer support. Peer support being, we have been there, we have done that, we can help you. It's also a case of reassuring you that the fact that you may have lost a breast doesn't mean you're any less of a woman.
Right.
Because although breasts are an important part of womanhood, you are not your breasts. So
Absolutely.
so we try to rebuild your self-esteem. And then the other thing is, I don't think most people understand the kind of costs that are related to a breast cancer diagnosis and treatment. I
Mhm.
mean, there are costs in terms of, well, thankfully, there are lots of companies now that are offering mammograms, in that they will say they're giving the Cancer Society 100 mammograms to be given to women who can't afford the mammogram. So there is screening. There is no screening facility in the public health sector up to now. I'm sure Dr. Copeland will
But
nod his
Dr.
head in
Copeland will
agreement.
speak on that a little later on.
Right. So
Yes.
there's that first cost of screening. Then you have the costs of biopsy, as he tells you, you need to go get your own needles, etc. Then they find out what type of cancer you have. Then you have surgical costs. Well, there is surgery in the public health sector. But if you're doing this privately, then it's through the window in terms of costs. Then, of course, you have treatment costs, um, radiation, chemotherapy, Herceptin if you're HER2 positive. All of these things can
Right.
run you into millions of dollars. And the average woman does not have that kind of money. So we try to help with the financial assistance. Clearly, we can't give you $1 million or $2 million to do
Right.
physiotherapy. Sorry, not physiotherapy, radiotherapy. But we can help you with your needles. We can help you with an MRI. We can help you with an ultrasound. We can help you with a scan. So persons who find themselves in a position that they need financial help to get these things done, come to us and we help. No, how much can we help? It takes cash to care.
Here.
And Reach to Recovery is well, we are the breast cancer support arm of the Jamaica Cancer Society, but we are self-funding. So we have to go out and raise our own funds. And we have been doing a run for the last 20 years, well, 22 years. There are 2 years we didn't do it. So
Right.
this year is our 20th
Because of
anniversary.
COVID.
Because of COVID, we didn't have a run for 2 years. But that is our primary fundraiser. And the money that we raise from that is what makes the wheel turn in terms of helping
Right.
women. This year,
Right.
we're doing a fun run. For the last 4 years, we have done a fairly competitive run. It's being sponsored by ICWI. They're a title sponsor for the last 5 years. And it used to be based at Emancipation Park. This year, it's based at Hope Gardens, and it's on October 30th, 6 o'clock in the morning. And it's a fun run. It's 5K, so you're still doing your 5K run, but it's going to be based at Hope Gardens. And we're hoping that we will get really good support because we need the money. We
Right.
need the money to save the lives of so many women who are diagnosed with breast cancer and are unable to access tests and treatments that they need to get done. So,
And
I
for the
would
fun
like
run, I know you
to
have nice merchandise. So where can we get those, and what's the cost of those merchandise?
well, let me put it this way. Merchandise is on a first come, first serve basis. And it is, how should I put this? It's at a premium at the moment. So you need to come in early to get merchandise. We're selling t-shirts for $1,500, and they're pretty, really pretty big
Mhm.
t-shirts. They come in black and they come in pink. We are selling socks, tall socks for $800, and the
Because the
socks,
theme is tutus and tall socks.
tutus and tall socks.
Mhm.
So we have the tall socks for $800. We have tutus for $1,500. And those are really hot items.
Mhm.
So it's a case of please come quickly if you want a tutu.
And then
And
you have
then we have caps, and our
right.
caps are in pink or black or white. And of course, they have the pink ribbon on it. Um, so those are basically what we're selling. We're selling shirts, we're selling tutus, we're selling socks, and we're selling caps. And
And
we have the
and
secretariat. The
yes.
secretariat where all of this happens is upstairs, the Toyota showroom. So you can come into Toyota, look at their wonderful cars,
Mhm.
and then you go upstairs and purchase your merchandise, come back down and imagine yourself driving out in a Toyota
And this is at
2019 Land
93 Old
Cruiser,
Hope Road.
Old Hope Road.
93 Old
Yes,
Hope Road, yes.
yes.
And do you have the numbers handy, or
The
do we have to go on the
secretariat,
website?
yeah, we have, well, there is a Pink Run website that you can go and register. Oh, registration also. You have to register for the run, and registration is $1,500. If you have a group of 25 or more, if you have a team of 25 or more, you get a discount. Your registration is at $1,200 per person.
Mhm.
Um, but where was I?
The website
The
address
website. The
is right.
website for the Pink Run is pinkrunjm.com. That's
Right. And you can get all the
pinkrunjm.
information right there.
Everything is there.
And for the rest of the month, what are we doing anything to show that we are supportive of breast cancer?
Oh, yes, we are. We're inviting all Jamaica to be our breast friends. And I'm sure the men would be happy to be our breast friends.
Mhm.
And we're having on every Friday this month, Breast Friends Friday. And on Breast Friends Friday, you wear pink, something pink to support us. We
Right.
need your support. We need your
Wonderful.
presence. So every
Wonderful,
Friday,
wonderful, wonderful.
Breast Friends Friday. It's a new BFF. You know, BFF used to be
Right.
Best Friends Forever. Well, now it's Breast Friends Friday.
And as you're wrapping, I'm not going out to the run. How else can I donate to Jamaica Reach to Recovery?
Everybody now tends to have online banking. So if you want to make a donation to Reach to Recovery, just get your pen. The bank account is NCB Matilda's Corner, checking 3718825545.
Yes.
37188255. You see how I know that offhand?
Yes, wonderful. Thank you so much, Caroline. Well, Caroline will be leaving us. We want to thank you so much for all that you do as chairman of Reach to Recovery, because we know it's an uphill battle to, especially at this time, right out of COVID, to for us to be asking persons to donate. But we know that breast cancer is a 24-hour job, and it affects every family. that I know of, everybody in families, somebody is touched by cancer of some kind, but in particular, breast cancer really affects the mothers. So I just want to thank you. We will catch up in the month as usual. Thank you so much for stopping by.
Thank
So we
you.
thank you so much. So we go now to we want to have we heard from one survivor and the chairman of Reach to Recovery. So we want to go over to Dr. Copeland. Welcome, Dr. Copeland, Jason Copeland, who is a breast surgeon, and he's going to tell us a little bit about himself and where we can find him and what he does and why did you choose this career and the challenges that you're having.
All right, thank you so much. Good night, everyone. Thanks again for having me. Again, I mean, I've been here before, and it's always wonderful to meet with you ladies and to.
One second, Doc. Please, my friends online, please remember, if you have any burning questions after Doc has spoken and after the ladies have spoken, or even during the conversations, you can just send your questions by texting in your questions online on YouTube, and we will have your questions answered. Thank you. Go ahead, Doc.
Yes,
Sorry about
sure.
that.
Thank you. So I was just saying it's always wonderful to meet with your group and to see what you guys do. It is really so important. Um, in terms of what I do, I'm a breast surgeon and a breast surgical oncologist, and the terms are perhaps new to a lot of persons. Generally speaking, in Jamaica, over decades, breast cancer is usually treated by general surgeons, and I'm a general surgeon by basic training, but I did further fellowship training in breast surgical oncology in New York State, and I came back to Jamaica in 2020. And since then, pretty much I hold two main hats, one in the public sector, the Kingston Public Hospital, where I serve as the clinical director of the breast oncology clinic there. And privately, I'm the founder and the clinical director of the Breast Health and Oncology Care Center at Andrews Memorial Hospital. So pretty much I do work and treat a lot of breast cancer patients on a daily basis. So I will speak a little bit about breast cancer in Jamaica in terms of what I see, because very often when we speak about breast cancer, when you read any pamphlet or so forth on breast cancer, it's typically talking about what is seen in North America or Europe, and not really so much about what we are seeing in Jamaica and in the Caribbean. So, breast cancer, as we all know, is the commonest cancer occurring in women in Jamaica, and currently it accounts for one out of every three cancers diagnosed. It used to be one out of every four, but it's now one out of every three.
And the others would be like cervical
Cervical
and
cancer,
popular ones.
cancer of the uterus are the two next most common ones. There's also lung cancer, colon cancer, of course, but breast cancer is number one by a long margin, actually, because if you add
Wow.
the next
What kind
three,
of numbers we're looking at, Doc? You have
well, in
any
terms of,
stats?
yeah, sure, in terms of numbers, so we can look at it two ways. So the average woman who's born in Jamaica has a lifetime chance of developing breast cancer of 7%, or 1 in 15. If you look at data from 2020, the Global Cancer Observatory, we had over 1,200 women diagnosed with breast cancer in Jamaica that year. And if you look at 2 years before that, which was in 2018, it was 900 and something. So it's not just that the numbers are high, but there
It's
seems to be a
increasing.
general increase in the incidence of frequency of breast cancer in our population. So that really is a big concern for us. So beyond just the numbers in terms of the frequency, we have to look at the mortality. What is the likelihood of a woman who's diagnosed with breast cancer in Jamaica actually dying from the disease? And the most recent estimates have it as about 50%. So
And that's high.
that is really high, and it is disturbing because if you look at the North American figures, they're at about 20%. So we are 2 to 3 times higher in terms of our likelihood of dying from breast cancer.
And what would the reason for that, doc?
So that is a really wonderful question, because that is where research comes in to play, where we're able to look at our patients, study the types of breast cancer that we're seeing, and try to look at the differences and see what accounts for this difference. And we actually did that. We published a paper last year looking at some of these differences that might be contributing to it. And so one of the things that we found was that breast cancer in our population occurs almost 10 years earlier than what they see. So a lot of our women are in the prime of life, in terms of their reproductive prime, social prime, economic prime. A lot of our mothers are breadwinners, primary breadwinners for the family. So we have a lot of cancers occurring younger, and in this younger group of women, the cancers tend to be a little more aggressive. So we're seeing cancers that are of higher triple negative breast cancer rates, for example. When we speak about breast cancer, there are different types, and one of the more aggressive type is a triple negative type. We are seeing twice the rates of triple negative breast cancer in our population than they are reporting in the United States. So those are some of the things that help to account for the higher death rate. Also, unfortunately, our patients present much later in terms of the
I was
stage.
about to ask you, do you see our women coming in to do mammograms on their own, or are they it's usually at a stage where they are sent because they present being unwell?
So a lot
Are
of
we
our women,
proactive
yeah,
or not?
a lot of our women shy away from doing the mammograms. We also looked at that in the study, and it was about 20% of our women were actually having any sort of screening mammograms over the previous 5 years. You compare that with the American figures, and they were well over 70%. So that's a big problem that we have. A lot of our women are not actually coming forward to do screening mammograms. And when they actually come in to do a mammogram, it is a diagnostic mammogram. They already found a lump or some problem that they need to investigate, but that's not screening. We need more for women to be doing screening mammograms. And that was a big difference as well.
The fact that our rate is so high, has it been linked to anything? Is it our diet? Is has it been linked to anything in particular, or we still guess it's still guesswork?
Well, breast cancer is common worldwide. This is not unique to us. And in fact, in countries, North America, Western Europe, the incidence there is actually higher. The problem is not so much the incidence. The problem is really the death rate. Those factors that cause us to have a higher death rate, because they have a higher incidence than we do, but their death rate is low. One of the things
Because
that you
they check.
Well, one of the things is that they check, but they also see a slightly different type of breast cancer than what we see. Because of our Afrocentric dominance in terms of the population, we see a lot more of the aggressive type, triple negative type. That is what tends to be seen in patients of, Afrocentric descent. And so that's what we commonly see.
What about access to screening? Is that a challenge for us?
It is a challenge for us. I mean, over decades now, we have not had a mammographic screening available in our public hospitals. And if you need to get mammograms done, up to now, you still have to go privately. Now, because of what I do on a daily basis, I'm aware of plans to have mammograms available in the public sector, but to date, it's not yet available. Hopefully, by the end of the year, we'll have at least two facilities in the public sector being able to do mammograms, and that will help. But we need a lot more than just two. But at least that is somewhat of a start, I believe, for us.
And we're talking about that's just the beginning. After screening, now they have to go on to well, based on where they are at, if it's late stage or whatever. You're talking about medication. You're talking about people have to be maybe being on tamoxifen, then going on to chemotherapy, then going on to radiotherapy, and the cost. What kind of costs are we looking at?
Yeah, so you have mentioned, quite a bit of disciplines that are involved in breast cancer treatment, and this is one area that we're also lacking. So in North America, for example, you have these comprehensive treatment facilities where you can have all of these multiple specialists in the same area who are able to see the patients and offer them a more integrated care. Now, we typically have a more fragmented system here, and we're trying, to change that into facilities, as I mentioned before, the Kingston Public Hospital Oncology Clinic, the Breast Health Oncology Care Center at Andrews Hospital. And we're trying to see if we can get more integrated in terms of how breast cancer really should be treated, because that is the way it should be. With respect to cost, breast cancer care can be extremely expensive. And I'll give you some examples. When it comes on to radiation therapy, you're in a private setting, you're looking at well over $2 to $3 million for a course of radiation treatment. And if women present late in their stage, very often they will need radiation treatment because radiation treatment improves the overall survival of these patients. Um, Chemotherapy as well is quite expensive. If the patient is HER2 positive, you're looking at Herceptin drug therapy, which is about $5 million per year. So, you know, the take home point here is that the later you present, one, the more extensive the treatment surgically, as well as adjuvant therapy, and overall, the more expensive it is. So we do want to see women presenting much earlier when we can. In some cases, we can surgically save the breast. We don't have to do these morbid
Radical
operations.
mastectomy.
That is correct, because a lot of the world has moved away from these radical mastectomies, and we can do breast conservative surgery. We can do sentinel lymph node biopsy. We don't have to take all the nodes of the axilla. We can avoid radiation in a lot of these women as well. So, the earlier you present, it's the better overall for your treatment and for the overall cost of care.
Um, with your experience and um, how can we best get the word out? Should this conversation start at high school? Should it start in the churches? What can we do to increase awareness and to help persons? Because the once a year October month thing not gonna cut it. Based
That's
on
correct.
what you're saying,
That is
the once
correct.
a year October month thing is not gonna cut it. So what can we do? You have any idea what we can do to kind of ramp up awareness?
So, breast cancer awareness has to be a part of what is ingrained in us as a nation. We need to understand more about it. For example, the projection is that these figures that I'm speaking about will go up by 50% in the next 30 years. So if we do not get comfortable speaking about breast cancer, understanding breast cancer, speaking to our young women about breast cancer, what you're going to find in the next 10, 20, 30 years' time is that we will be overrun with this disease. So, yes, we have to get into the schools so that our young women and men as well, because breast cancer can occur in men, but overwhelmingly in women, of course,
Right.
understand about the disease process, how to check their own breasts, when they should start breast cancer screening. And of course, it should not be limited to the month of October. October is just to raise the awareness, but this conversation, these meetings, they have to continue throughout the year. So I do get a lot of requests to have these talks in October, but these talks, they have to continue. And I'm usually
Straight
willing
through the year.
to do these talks to raise awareness. I do speak to church groups, high school groups. I was at the university just a few days ago speaking to young people because guess what? The youngest patient that I've had with breast cancer was 19.
Well,
19.
when I joined Reach to Recovery, one of our youngest members was she had breast cancer at 16.
There you go.
She took out her first lump, which was benign, at 13. It came back, and she was diagnosed with breast cancer at 16.
Yes.
So,
Yes.
I mean, it might be shocking to say, excuse me, let's start the conversation. Oh, excuse me. Let's start the conversation in schools, but it can start early.
That's correct. That's correct. And once we understand that, then we'll see it's not a big ask to start this conversation with our teenagers. So when they
Right,
get to 20 and 25, they're doing their regular breast self-examinations.
right.
They're going to their doctors and having clinical breast examination done. And they understand that if they're average risk, when they get to 40, they're about to going to start their mammograms, and they will be more compliant, because compliance is a really big issue. Some women do they do one and they never go back 5 years, 10 years later. So that understand that it has to be that compliance with annual screening is not a one-off. You have to, make this a regular part of what you do.
All right, there are two things sometimes that we don't address. The fact that persons do think, do believe in Obia family curse, because we do live in that kind of setting sometimes, people in, especially in rural areas. So those are some of the things that prevent persons from coming in. Somebody Obia me, somebody, there's a family curse. There is all of those myths. So I suppose with education, um, a lot of those things will go away, but we have to push,
Yes,
you know?
yes, yes. And we have women as well who haven't found a lump in the breast. They will also seek solace in some of these places as well to say, well, they're not going to doctor, but they will go somewhere else and they'll use this oil or this bush or other things like that. So yes, the education, the population-wide education will also help to remove some of these beliefs and these attitudes towards breast cancer.
Okay, I'm gonna come back to you, Doc. Remember, please, ladies and gentlemen. There's a question for Doc. He said, She said, Andrea, thanks for joining. You just said that breast cancer treatment is moving away from radical mastectomy to targeted surgery. However, every breast cancer survivor I know did a radical. Is it that we in Jamaica are not moving toward the less invasive surgery, or
So that's a very accurate observation. We looked at it as well in the research. I really believe that we should research everything about breast cancer in Jamaica. So we looked at that as well, and we found that roughly 95% of our patients were getting the mastectomy, and reasons for that are multifactorial. But what you find is that a lot of our patients do present early enough. When I say a lot, roughly about 50%, because we looked at it, and about 50% of our patients presented early enough that they could possibly get breast conservation. But your treating team really has to it has to be something that they do and do quite often, that they're comfortable doing, that they're confident in terms of the skill set and so forth, that you have the radiation support to do it. And it shouldn't be that the radiation is tacked on at the end, but that discussion is had at the beginning when all the specialists can come in and have a targeted plan for that patient. So we want to change as well how we manage these patients. When we see the patients up front, is not a fragmented approach, but a comprehensive multidisciplinary approach. And if we can do that, we can actually transition, like many other countries have, to more breast conservative therapy and away from some of the radical surgeries, which in many cases are not actually beneficial. So very astute observation, and we've also looked at it, and we are moving away from that. We have started looking at it through research and in our clinics, and what we've found is that since we've started the clinics, guess what? We are moving away again from the radical mastectomies. In a lot of cases, some women will still need it, but we've been moving away from that as well. And that's what we want to, that's how we want to approach the new sort of
is
approach to breast cancer.
in terms of survival, is there any advantage from one or the other?
So most of the data, and the good thing and the bad thing about breast cancer is that it's very common. So we have over 2 million women diagnosed worldwide with breast cancer every single year. So that allows a lot of studies to be done. And no, for early breast cancer, and this is, I want to be very clear, for early breast
Right.
cancer, that's stage 0, stage 1, stage 2, there's no difference between having your breast conserved and having radiation therapy and having a radical or modified radical mastectomy. There is no difference.
Okay. Thank you so much. Okay. All right. Hi, Mrs. Ramsay. Good night. Unmute. Unmute. No, you're still mute. Hi, Miss
Okay.
Ramsay.
Hello, my dear.
How are you?
I am fine, thank you. Fine,
What
fine.
I want to invite Mrs. Ramsay and her daughter Charlene.
Charmaine.
Charmaine. Charmaine is her caregiver, and I have known them almost all. You and I joined at the same time, Mrs. Ramsay.
About the
What
same
year did
time,
you
about
join?
2000, I think
2000.
2000.
Yes,
Yes.
we joined at the same time, and I want to show off that Mrs. Ramsay is now 91. You see how
Yes.
she hot? And we joined 2000. So you were diagnosed at what age?
70. At
70.
70.
Right.
Yes.
And just give us a little of your story.
Okay. Well, I usually hear about breast cancer, and I was really scared of it. So I found out, how do you go about it? And they said, just have a mammogram, and test it and see that there is none. So at 70, I started doing the mammogram regularly.
Oh, you never did a mammogram before 70?
No. At the age of, on my birthday, I made it a duty to do it every year. And this year in question, the doctor called me back, just like he did with you. And he said, I think we need to do a second one. I said, what happened? He said, everything will be all right. And I'm wondering, if everything is going to be all right, why do it again? But I did. And then I discovered that there was a lump there. Of course, that was not pleasant to hear that there's a lump in your breast after all these years. You've had this lovely breast and no problem. So I said, what's the next move then? He said, well, I think we'll have to do surgery. I said, wait a minute. Let me check this out again. And so my daughter, Charmaine, has a very good friend who is a nurse. And so she got a specialist to look at it for me. And he said, yes, there is 2 there. I said, 2? Oh my God. 1 would be bad enough, much more 2. So I did that at about six weeks after I discovered that there was 1. I had the breast off. Of course, at first I didn't.
You didn't find a lump yourself at all. It was the mammogram that found a lump.
Yes.
Okay.
And then afterward, you feel it there. And then I went to this specialist, but I wouldn't tell him where this lump was after knowing where it was. I said, let him find it himself, in case there is some more. Mm-hmm. Well, after I have it done, I went, and in December of 2000, I had the surgery. And I said to the doctor just before surgery, I said, can't you take both off? Both breasts? They said, no, I won't be so drastic. Why take both off? I said, well, okay. So I had this off. And then I started treatment right away. About 6 months after, I had all my treatment, mammogram, everything done, radiation, chemo, the lot. But there was one thing I was very scared of, the swollen arm, where the fluid goes down to your hand. I was dead scared of that. I saw someone with it, and I asked her why she had this arm. I thought it was some circulation, and she said, she had the breast off. And I said, oh my God, how do you prevent this? And she said, I think there is a special sleeve that you have to buy to wear. And of course, I got that right away, even before it started looking like it would be swollen. And I wore that sleeve for 3 years. I never had any swollen arm, so I was happy about that. Mm-hmm. Had all my treatment, as I said, and since then I've been quite comfortable with it. You wear this prosthesis and you feel quite womanly again. And I have no problem. No, I have this saying that it's better to have breath and no breast than have breast and no breath. and so on. And I've been happy. I go about like nothing. And I
Yes.
advise everyone, the
Right.
early detection is the key. Early detection, if you have suspicion that there's a lump there, go and find out what it was. And from there
That
on,
that so,
I
so,
just,
so you being proactive, albeit at 70, you
yeah,
were able to save your life by doing the
at,
mammograms
and I'm now 91, going 92.
and
So I give no problem.
traveling like nobody's business. I love that. Charmaine,
Thank you very
join
much.
us as a caregiver. What was that for you? What was that like for you when
Um,
I'm assuming you went with mom or you didn't go with mom or mom came home and told you.
yeah.
What was that like for you? And how did it affect your mental state saying, okay, mom had breast cancer. Is this going to be a part of my life or whatever? How did you cope with this?
Well, I think initially, well, good evening, everybody. I think initially when I heard, I cried. I think we all cried. We sat around we're sitting around the dining table. We have a dining table where we all meet for discussion and stuff. And we sat around this very dining table. And I think we cried maybe for about 2-3 hours. We went through a period of denial. And then we decided we have to do something. How are we going to deal with it? And so you go through different emotions, confusion, you question everything. I mean, is it really happening to us? Us as in this family, because my family is very
Right,
small. My family is me, mommy, daddy,
right.
and then friends. So I'm their only child. So, why kind of thing. And then you come to a point where you have to accept it. Once you accept, what are we going to do? And I think that process of acceptance was kind of easy because mommy accepted it. And so we all got on board. We decided how we're going to do it. We spoke with specialists, and as mommy said, within quick order, we did the surgery. One of the things, though, I will say, which makes a big difference, is prayer. Prayer. Prayer doesn't always answer the questions the way you want it, but it gives you that support. It gives you that that support that you need, that only prayer can. That strength. Thank you. That strength that only prayer can give you. You also, for B, as I said, my family is small. You get support from people. It doesn't always have to be family, because sometimes family have no clue how to deal with this.
Right.
And sometimes when you would expect them, they can't give you the support. So support comes from friends.
Right.
It comes
Did
from
going
your
to reach the
church.
recovery make a difference for you?
Pardon?
Did going to reach the
Sorry?
recovery make a difference
Yes, it did.
for
And
you?
that was one of the support groups. That was one of the support groups. So I have on my support group, my friends, my church. There were even people that you did not know before this incident that just popped up, and they were there for a period to help you through that and reach the recovery. Reach to recovery gives you a different kind of support, because normally everybody else, as I said, won't make to say anything. But
Mm-hmm.
when you go through it, and that's what the people at Reach to Recovery, they can tell you, they can
What to expect?
explain to you what is going on. When
Mm-hmm.
you're feeling nauseous, when the hair drops out, where do you, if you need to get a wig, or is it that you just cut it off and just deal with it? They have walked the road, and therefore they can tell you exactly little exercises that you do, because mommy, as she told you, was very fearful that you get flabby arms. And there are exercises that she did, maybe simple, but it helped. And it's only the people who actually walked the road who are able to tell you these things. The other thing that I think I'd really like to share is that through all of this, it has given me an appreciation for life.
Absolutely.
And I think it changed my mom as well, because she's a go-getter now. She is ready to do anything, anytime, anyhow. Just say, can you? Do you
Isn't
want
that
to? She's ready
fantastic at 91?
at 91, right? And so in the morning, it's like, God, thank you for waking me up this morning. Thank you. Yes, you may have pains, you have problems, you have issues, but you are alive. You're above earth this morning. So this appreciation for life, the appreciation for people, what people do, and it doesn't matter how big or small. But, well, most of the time it's the small things that really count, you know. So
Absolutely.
the appreciation for life, and reach the recovery, thumbs up, strength.
Thank you so much for that. And we go over now to Latoya. Now, Latoya is a youngster, um, and a newbie, right, Latoya?
All right.
Good night, everyone. Good
Good
night.
night.
No, I'm not a newbie, no. I think I'm an oldie right now.
So, when were you diagnosed? Tell us
I was
your story.
diagnosed. I was diagnosed in 2002. I was diagnosed in 2002.
Oh,
When I
so
was diagnosed,
okay, so you're old then.
Yes.
when I diagnosed in 2002, I thought that breast cancer is not for
Young.
young
That was at
persons.
what age? That was what age?
At the time, I was 19.
Okay. So that's
So
why I thought you were a newbie. So you're so young. Okay, that,
thank
that
you.
must have been frightening for you, Latoya.
Um, I didn't realize it until like years after. So when I was diagnosed and I did the surgery and everything, I just figured that breast cancer is not for young people.
How
So
did you
after
find the lump?
I had a lump from I was a little girl, in my left breast that I used to suck my tummy, so that made me stop sucking it. So I used to suck my finger and play with the lump. So I had it for years. From I was very, very young. From as far as I can remember, I remember having that lump.
Mm-hmm.
And it was there until one night I went to bed, and when I woke up in pain. When I woke up, the nipple of the breast was red and stuff was coming out. I started crying at the time. I had a friend who was living across the road. I run over to her house like 1:30 a.m. in the morning, and I woke her up and I show her. I mean, her husband was there, but I couldn't care less. So I'm like, what is happening to me?
Mm-hmm.
And she was shocked because she was like, she don't know what is happening. Immediately she rushed me to KPH that night. Um, in the morning of the same night, I had to do a emergency mammogram. That's what they called it at the time.
Mm-hmm.
Emergency mammogram. When it comes back, it was the news that I didn't want to hear, but I blocked it out my head. In 2 days, I had a surgery. Um, and then from there, I think I was doing okay for until a couple of years. It comes back, and this time it came back more aggressive. And this time it came back, it spread all over the body. So it's no longer for me. It's no longer breast cancer. It's now secondary breast cancer that spread throughout my entire body.
So what was your treatment like?
I had radiation. I had chemotherapy. Um, I had intense radiation. I have radiation here in Jamaica, and they had to rush me overseas for also to do an intense radiation. That was how bad it is. Because what happened is that it spread to my brain. It gave me a tumor, and that tumor is secondary breast cancer tumor. It spread to my lungs. Had one lungs now because I lost one. It also spread to the blood. And so it's not a different kind of cancer, it's breast cancer. It's
But
now
secondary.
secondary breast cancer
Well,
that
Doc,
spread
Doc
to
will
the liver.
explain when you're through.
Yes.
I had no
So
idea. Well, first of all, I didn't know your story. I'm just hearing your story for the first time. That the fact that you're even able to smile, that alone is absolutely amazing. And you're how old now?
I'm 38. I'll
So
be 39 soon.
even with all of that you have gone through, you were still able to survive and clearly doing much better now. What is your I don't know if you want to say what your status is now.
Well,
Still doing treatment with
I
meaning, are you
am
still doing
I am still
treatment?
doing I'm still doing treatment because what it has done to me, it has some persons know my story before. It had blind me where the tumor was resting on the retina of my eye, so I lost my sight for 5 months. With intense radiation, they got to shrink the radiation, and then I did a laser surgery overseas to get rid of that. Um, so I also got it gave me a stroke where I couldn't walk and I couldn't talk. And as I said before, I lost one of the lungs. So
Mhm.
you know how we lost the lungs because of that. So I had to learn how to see again, learn how to walk again, learn how to talk again. I basically had to learn everything all over.
But Latoya, you're smiling, you're laughing.
I
I see
have
you, you
to.
are dancing. I see you at the launch and you are all over the place, up and down. You are absolutely amazing.
Thank you.
How
Thank you.
how do you cope mentally?
Um,
Let our audience know how you get up every day and do this.
the grace of God is one. I have excellent support. I can tell you, my husband is a excellent support. Family and friends are very supportive as well. Um, my son is my most
Your biggest supporter.
my he's my super cheerleader, and I can tell you why. When I was diagnosed, I didn't have a child. I was told by a doctor that I might not have a child. I went ahead and get pregnant. No, my son is born. Even though I never liked, the father thing, I really never wanted for that kind of man. But because the doctor tell me say me can't get pregnant, I purposely went and got pregnant. When the child was born, a friend of mine, she died, God rest her soul, and she died from breast cancer. She told me to abort the child. So now you see why my son is my biggest cheerleader.
Mhm.
Um, I bring the child. When the child was born, because I had him while I was diagnosed, he was born with a rare disease that called G6PD deficiency, which his red blood cell break down easily. That's a different story. But that child was born during my sickness. Um, he, I tell myself every day that I have to live for him. I don't tell myself that I have to live for me because I am the one who went and get him. So I had to ensure that he is okay and comfortable. No, I can tell you, he is 17 years old and he's at aviation school. So now you see why he's my biggest cheerleader. I have to live because I want when he fly for the very first time, he said his mother is on board. So I am very happy just to be alive and just to watch him grow.
That is
When
an
I went
amazing
overseas to
story.
do treatment, I was sent by a doctor. And I love Dr. Forbes. Love him very much. I was sent overseas to see another specialist. That was how bad the cancer is. Because Jamaica has beautiful doctors, lovely doctors, but we lack equipment.
Mhm.
That's our biggest problem here in Jamaica. We lack equipment. If Jamaica could get some of those equipment, we survivors would be doing excellent here. When I went, the doctor overseas, he looked at me and he said, "This is the dead coming from Jamaica." I mean, he was playing with me. He didn't know me from anywhere. And I had to shut him down quickly. I let him know that I am not a dead and I will not die here. After a couple months, he told me that he had planned to call my husband and tell him that I am no more, and he has to make arrangement to pick up my body. No, I love doctors very well, and doctors are not God. And I love them because God gave them wisdom. He was making much of me. He didn't know that what is fun to some person is death to some persons.
Mhm.
And we can't call it down on ourselves. And because of that, I had to live. I had to show the doctors that, listen, I am a fighter and I will fight to the very end.
That is an amazing story. Now, before I go back to you, Doc, I was told the very same thing because when I was diagnosed, I was 35, had no children, but I was told that, um, well, and have seen where the pregnancy state increases because it's the hormone it's breast cancer is hormonally driven. So you are
Yeah.
encouraged
Not
not to
to.
have not to get pregnant. I was encouraged not to get pregnant as well. And I have what I have later seen where persons save their eggs and try later on to get pregnant. What is the status now on pregnancy, doc? And I have some other questions here online. But what is the current status on um, breast cancer and getting pregnant?
Right. So you're very correct in saying that we used to advise women haven't had a breast cancer diagnosis that pregnancy was really discouraged because we thought that the hormonal changes in pregnancy would encourage the cancer to come back and possibly to spread to other organs. We have realized that that is in fact not true, and so you can get pregnant after a breast cancer diagnosis. What we generally recommend now is that in the first 2 years after the diagnosis, where you're getting still under treatment, and two, the risk of recurrence is highest, that you should not get pregnant within that 2 year period. Some women who are hormone receptor positive would be on anti-hormone therapy for a period of about 5 years. And for those groups, we said, okay, you take your hormone therapy for the full 5 years. Then after that, you can attempt to get pregnant. So pregnancy after breast cancer is safe, and we no longer tell women that they should not get pregnant after breast cancer. We've realized that that is not true. You can get pregnant after breast cancer safely soon.
Um, when Andrea had said about when Andrea was asked, I believe is it a question? She said someone did a radical mastectomy. No, did a radical mastectomy while everyone who has died did lumpectomy. Is it that back in the day, um, persons why did we switch to mostly radical mastectomy? Is it that persons the survival rate was less?
No,
Can
actually,
you continue there, Mike, please? Yeah.
yeah. Actually, that. Oh, by the way, Latoya, really thank you. Very inspiring story. Very,
Yes.
very inspiring story. That was wonderful to hear it and to see your drive and your passion for life. So thank you
And
for
she's
that.
also asking what has changed
Thank you for
from
that.
the going from
Actually,
the lumpectomy and the radical mastectomy.
yeah, it's actually the other way around. We actually were doing the radical mastectomies for a very long time from the 1900s. The
Hmm.
lumpectomy is actually the more recent operation that has come on board because we're doing these radical surgeries, and they were even extended radical, and they were very deforming. We would take away the breast and the muscles, sometimes even ribs, and you can imagine how deformed these women were. And what we found over time is that this extensive resection was not really beneficial to the patients.
Mhm.
And so we've been coming down and down and down to now in very selected groups, if these are early breast cancer patients, and we go through and we look at all the features of the cancer. We make sure it's a single focus in the breast and that sort of thing. And if you select the patients well, they do just as well as a person who's had a mastectomy in today's world, right? With today's technology, we can do a lumpectomy or a wide excision along with radiation of the breast with outcomes in terms of survival outcomes just as good and in some cases better than a mastectomy. And then obviously there are other benefits in terms of psychological benefits and sexual, psychosocial, psychosexual, etc. So the world has really moved well away from mastectomy in a lot of cases, if in well selected patients.
Right. But and I also and you also remove you move from I believe in the earlier days they used to remove ovaries, they
Yes,
or radiate the ovaries, try to manage the estrogen level. Am I correct? So that is
yes.
also something. So the tamoxifen has replaced that.
Tamoxifen use, chemotherapy has replaced that. So we're not doing these radical, we're not doing the oophorectomies like we used to before. So we were, I
Right.
mean, at that time we did not have, the drugs, we didn't have the large research and so forth. So the surgeries were quite more extensive. Now we realize we don't have to be that extensive, and we can get even better outcomes.
Charmaine is saying that are some patients well some patients do radiation and chemotherapy before the actual surgery. Is there a reason for that?
We do have some cases, and those are with the patients who have more advanced breast cancer. So we're not talking about early breast cancer here. These are patients who would have presented late and in some
Okay.
cases have disease that we need to get under control so we can actually properly operate. Some women, they're inoperable when they present. The cancer is, fixed to the chest wall, to the muscles, and we have to give them chemotherapy, radiate them to downstage it to shrink it so we can actually operate.
Okay. To give them a better chance at managing the tumor.
That is correct.
Okay. Carlene Thomas is asking, she says she's or making a statement. She says, when I was in my late 20s and early 30s, I was told I was too young to do a mammogram. I'm now in my mid 40s and haven't done one yet. Can you just explain to Carlene why, based on the density of the breast and yada yada, yeah, why they say not before 40?
So when we talk about screening, we look at the not just the age, but we have to look at the risk. If you're at average risk, we believe in starting at 40 because the studies have shown that the survival benefit that you're going to get from regular screening mammogram really starts at about age 40, thereabouts. Under that, there's really no survival benefit. However, if you have a high risk of getting breast cancer, for example, strong family history of gene mutations and so forth, we will start the breast cancer screening earlier, even age 25 and 30, if you are high risk. So it all depends on what risk category you fall into. But
And
yes,
when you
for
say
you,
high risk, doc, what do you mean? Can you say exactly what is high risk?
yeah, high risk. So you have a strong family history. You have a lot of first degree relatives with breast cancer. Your mother had breast cancer or your sister had breast cancer. A single first degree relative will double your risk. Multiple first degree relatives similarly cause the risk to go up. There are certain gene mutations like the BRCA, what person calls the BRCA gene mutation, which can increase your risk by 10 times. And so if you have these mutations as well,
Uh-oh. He he dropped out. His let's tell him to come out and rejoin. Latoya, is there anything you wanted us to know before until Doc comes back? Is there anything else you wanted to share with us? Because your story is really absolutely amazing. Unmute, yes. Go ahead.
Okay. So I was Doc was saying that family history of breast cancer.
Mhm.
On my mother's side of family, I am not aware of anybody on my mother's side of family that has this dreaded disease. But on my dad's side of family, I was told my grandmother, my aunt, my uncle. So I have family member on that side of family who have the disease. So I guess maybe that's why it was passed on to me. But I am a fighter, so I
You were
don't
never,
worry
you
about.
were never, nobody in your family. Okay, Doc is back. Nobody in your family though, share that information, right?
On my mother's side, no, because I had asked my mother, and
Coming back to you, Doc.
I am sure she said there's no one that has it from her side of family. But on my father's side of family, I was told that that's where I inherit
The
um
gene.
the genes. And
Okay.
because it's so strong on my father's side, so even if on my mother's side of family there are family members who have it, maybe they're probably late, maybe great grand or grand, because I know my grandmother didn't have it. So but I know that on my father's side my grandmother had it. I have an uncle who had prostate, I had an aunt who had ovarian cancer. So on my father's side, that's where I inherited.
Okay. Okay. Thank you, Latoya. Yes, Doc. Back to you. You were saying.
Yeah, right. Thank you. I got kicked off just now. So I was saying, so patients who have the gene mutation, the BRCA mutations, and there are other mutations as well, which would put them in a high risk category. So in those patients, we start the breast cancer screening much earlier because the age of onset of breast cancer in those patients tend to be earlier than in the average risk category patient. So those are things that we should bear in mind. Very often we tell women to get screened, but they really should also do a risk assessment so they understand what risk category they're in, and then we can best advise them how to get appropriate screening. Not everybody needs only a mammogram. Somewhere we need an ultrasound as well, especially if the breast is dense. And in high risk women, sometimes we even want them to get breast MRI as part of their regular screening.
Well, actually, as you say that, when I did my mammogram, well, I was 35. I found a lump myself. The thing is, where my lump was in my chest wall. It wasn't in the fatty part of my breast. So when I did my mammogram, it did not capture the lump. Well, the hump, because it wasn't really a lump per se. It was a thickening in my chest wall. So when I did my mammogram, the mammogram came back negative because it did not come up in the film. And so because I picked out a lump out of the same breast 9 years. So this is something that I was doing my regular breast examinations I was doing on a regular basis. So this was I had noticed the change. So I was absolutely positive that something had changed. So when I got up, he said, "Well, you're free to go. There's nothing there." And I said to Dr. Clark, "No, I am sure." He said, "Okay, do me a favor. Put my hand on where you said the lump is." So after that, he did an ultrasound, and the ultrasound showed the lump. And then I did a needle biopsy after that, which confirmed the diagnosis of breast cancer. So that's why that self breast examination and knowing your body is extremely important, because I could have gotten up off of that table and gone home, and then I would not be here having this conversation. So knowing your body is a part of saving yourself.
Yes.
You know, um, Carlene was also suggesting. She said, so now in sensitizing women and men, she's thinking that we should highlight cases or statistics of younger women who have been diagnosed with breast cancer, maybe including it as a part of the back to school message. medicals? I would assume in the universities or in the high schools. What are your thoughts on that,
Yeah, so
Doc?
the breast self-awareness is something that we recommend starting from the high school level, because you get more in tune with your breast, the look of it, the shape of it, the feel of it. Obviously, in girls in high school, the breast is still developing, but you are able to get that feel as to what my breast feels like. If there's something
Right.
abnormal, persistent abnormality, you can present that to your physician. So absolutely, yes, I think we should really start that education from the high school. And if someone is going to university, a breast examination should be a routine part of the clinical examination, and very often that is also done for high school medicals as well. So that is where the training, the discussion, the education has to begin from. If we're looking long term in terms of reducing the breast cancer mortality, these are some of the things that we have to be doing.
Is there any particular age that you would suggest we start doing screening? What would
So
you say is the age that person should start? Or as you said earlier, it's based on your history. But do people really check the history, their family history?
very
That's
often
another challenge.
very often they don't check, or very often you may not know because you may not have been told on your father's
People
side
don't
what.
share information.
That
So
is
that's
correct.
another thing that we need to encourage, sharing of information.
That is correct. Very often I meet patients and, haven't diagnosed them with breast cancer. They go back and they speak to their relatives and they say, you know what, they told there's an aunt who had it and there's another person who had it, but they just never knew before. So that sharing of information in the family when it comes down to health and cancers is extremely important as well. But to add to your question about starting, the breast self-examination really should start at about age 20. Right? That's a monthly breast self-examination. Clinical examination by a physician should start at that age as well, and that's once a year. And if it's an average risk, you always have to bear in mind the risk. If it's an average risk, you start mammographic screening at 40. If the risk is increased, they get a proper risk assessment done, and sometimes we start those patients at 25 and 30 in terms of their routine screening, 25 with MRIs, 30 with mammograms.
All
So
right.
that
So
would be the situation.
if I as a parent have a daughter or a son, as you said, sons can get it too. When should I start having that conversation with my daughter? If I am a survivor, or if my mother is a survivor, it may have missed me. Should I have that conversation with my daughter, and when should I have that conversation with my daughter?
Right. So you would start having that conversation with your daughter from she's a teenager. I think just to get her to understand about the family history and what is in the family. When she gets to around the age of 20, that's when we recommend starting that breast self-examination. Has not been shown to be of any significant value before that, but at
Mhm.
about the age 20 should start that breast self-examination. But I think the education should start before that while she's a teenager in terms of understanding about her breast, understanding about her own family history and what is expected as she gets older in terms of her own examination and care of her breast. And yeah, so that's what I would suggest, that she starts the education as a teenager, but the self-examination starts at 20.
Andrea is asking, does it make sense to have a genetic analysis to determine if one has the gene mutations that cause cancer?
So if you have a patient who is diagnosed with breast cancer as a young woman, and by young we somewhat arbitrarily use the age of 50, right? If certain types of breast cancer, like triple negative breast cancer, bilateral breast cancer in the male, those patients will routinely recommend that you do a genetic test in that patient. If that patient comes back and is positive, then you have an indication now to test other family members, their offsprings, and so forth. If the patient comes back and the genetic test is negative, then it's unlikely that they would have any of these high risk mutations to pass on. So the patient who has breast cancer should be tested If they're under 50, they have that triple negative breast cancer subtype, they have bilateral breast cancer, or if it's a patient with male breast cancer.
Um, Charmaine is asking, where does one go to get the genetic analysis done? Is it done here in Jamaica?
There are a few centers in Jamaica that serve as collection points. So you can go there and you can get swabbed in terms of a cheek swab. And then the actual sample is usually sent overseas. And usually in 2 to 3 weeks' time, you will have a result. So there are a few collection centers in Kingston and Mandeville and Montego Bay that you can actually go and get swabbed.
Any you can say on air?
I do use Island Medical Specialists quite often. That's Dr. Sherry Chin's office, and they usually swab, and in about 2 to 3 weeks' time, you get back a result. That's the one I say I use most often.
Okay. Is there any other information that you'd like to get? Because we're going to wrap up. We have another 10 minutes. So is there any other information that you'd like to get out, something that I haven't asked that you'd like to share with our online viewers at this time?
Yes, as part of the Breast Cancer Awareness Month, I just wanted to let your viewers know that one of the things that we are doing in terms of giving back, because we believe that women should be screened and should be able to have access to mammograms. Sometimes there's a cost issue. And one of the things that we are actually doing is that we are sponsoring mammograms here through the Breast Health Oncology Care Center at Andrews Hospital. Once the woman is between the age 40 to 60, that's a cutoff that we have used just for this program. They can call in, stop by the office, receive a coupon, and we have partnered with IIA on the waterfront downtown Kingston, where they'll actually have their mammograms done free of cost to them. Once they have their coupons, they go there, they get the mammograms free of cost. And once we have the mammogram report, we'll also include a breast cancer risk assessment so that the patient can understand their risk and be better able to know what to do going forward in the future. So they can just...
So they go to, where they call Andrews?
So they call into the Andrews Hospital, the Breast Health and Oncology Care Center. The number is 618-1810 or 920-7717. 920-7717.
And they are interested in what program?
It's a breast cancer screening program. It's for free mammograms. Runs for the month of October. Limited supplies, of course, but runs for the month of October. So these are for screening mammograms. Call in, make an appointment, collect the coupons, and you can go and have your mammograms done absolutely free of cost to you.
Okay, one thing that we didn't touch on, Doc, is that all lumps are not cancerous. It can be fibrocystic disease. Can you just say a little bit on that? So that way, if someone were to check their breast tonight and they find a lump, they don't panic, but they have it checked out.
So yeah, the majority of lumps that you'll find in the average woman is not cancerous. If you have, I would say, 100 women walking by, and if you were to do ultrasounds on all of them, you will find cysts, you'll find small lumps that they perhaps did not know that were there. The majority of them will be benign. Not to say that you should ignore any lumps that you find. No, it's really about education. The majority will be benign, and we're not trying to scare women, but we're saying take the appropriate action. You find a persistent lump in the breast, go to the physician. He will get you imaged, and based on the imaging, we will make a determination as to whether or not you need to get a biopsy done. Do we think this is something suspicious or not? So that would be my advice to women. It's not about scaring, it's about education.
Okay. And your office hours down, you said where's your office? For regular now. So, but the clinic is, what is it? The clinic you said? It's a breast clinic, right?
That's right. So there is the breast cancer clinic at the Kingston Public Hospital. Mm-hmm. My office privately is at the Breast Health Oncology Care Center, which is at Andrews Memorial Hospital, and that's Monday to Friday.
And the clinic hours is at what are the times For the
So
breast clinic, is it an everyday thing or
no,
it's
the
certain
breast
days?
cancer clinic is a specialist clinic, so that's a referral clinic. You'd have to refer to that
Oh, you
clinic.
have to be referred.
That is correct. That's a
Okay.
specialist clinic. It's at the hospitals, which is a tertiary care institution. So you have to be referred there. It's a specialist clinic for women who have breast cancer or are suspected to have breast cancer.
Okay. Anything else?
Um, no, I just want to say, thank you for inviting me to this program, and we need more programs like these to get the word out, to get that, to have that platform where we can speak freely, we can educate each other, we can ask questions, and we can all be better informed. I always learn so much just from the interaction um, amongst your panelists here, and I'd like to thank the members of the Jamaica Reach to Recovery, because you guys have also partnered with us at the Kingston Public Hospital through our breast oncology clinic as well. So thank you for that.
You are so welcome, and bless you for all that you do. And we really appreciate it. We know you're busy. We appreciate the time that you have given us tonight.
Thank
Mrs.
you.
Ramsay, over to you. Any last words? What would you like to say to the our online guests, online visitors, or Charmaine? Unmute. Unmute. Still muted. You're still muted. Still muted. You're unmuted. Okay. All right. There you go.
Oh, yes, I would say it was a lovely program, and all I would say to young women, early detection is the key. So don't be afraid. Have your mammogram, have your self-examination each month, and if you're not satisfied with whatever you might find, go and check it.
Thank you
Don't be
so much.
scared.
Thank you
Thank
so
you.
much, Mrs. Ramsay. And will I
Thank
see you on
you.
the chat, Mrs. Ramsay? Will I see you up at home?
Yes, definitely. I'll be up there. I'll be there. True. I will.
Charmaine, any last words?
No, but just to, if you find yourself in a situation where you do have breast cancer, make sure you're a part of the Reach to Recovery group.
Yes.
Make sure you listen, you pay attention, you follow the instructions of your doctors. Don't listen to hearsay, only listen to those people who have actually walked the road. And pray.
Awesome advice.
Pray.
Awesome advice.
Pray.
Thank
Thank
you.
you.
Thank you.
Latoya, the star of the show, because let me tell you, everybody online is in love with you. They love your spirit, your never die spirit.
Well, I can tell everyone, early detection is the key. That's the key. And you also have to have a willpower to live. Early detection can be the key for sure, but if you don't have the willpower to fight this dreaded disease, then you're in serious trouble. You have to have that power. You have to have that will. And once you have that will to live, then you will live. You will live.
Thank, thank you so much. Everyone, I just want to thank you so much for staying with us online. Yes, Doc, they're thanking you on online as well. I just want to remind you, ladies and gentlemen, we have a run coming up October 30th. That's Sunday morning, 6:30 at Hope Gardens. It's $1,500 to sign up. You can also donate online, and the reason for these funds, as Carolyn or Chairman said earlier, was the funds are to help persons who cannot afford the very expensive treatment, medication, tests, surgery, and we can't even help everybody. We can just help a few, and not even full help, partial help, but at least we can help with something. every mickle make a muckle. You know, my saying always is every mickle make a muckle, and we are here to help each other. Not everybody can afford to go to foreign to get treatment, so we have to do what we can do here. And we also need to remember that early detection is key. Early detection is key. Check your breasts every month, same time, before or after your period. In the shower or lying flat on your back is best. You do it in a circular motion on right around, squeezing the nipple to see if there's any fluid coming out of your nipple. What I was never told when I went to do when I was diagnosed was to check underneath my armpit. Check underneath your armpit. Check your neck areas to see if there are any lumps, bumps, any standing lymph nodes, because that usually means that something is happening. And it doesn't have to be cancer, it can be anything. So any lumps or bumps that you find, just have them checked. I like to say cancer is time sensitive. As you find out what is happening, or if you see a lump or bump, anything, go to the doctor immediately. Immediately. Don't waste, don't tarry, do not procrastinate. Early detection is key. You can save your life. You are responsible for saving your life. And don't be afraid to ask the doctor questions. That's what you are there to do. Ask the doctor questions. He will answer. And if he's not answering, find another doctor. Right? So, because you have a lot of good doctors out there. So I just want to say again, thank you so much for joining us tonight. We are so happy that you joined. And this will be posted on the Jamaica Reach to Recovery page. It will also be up on YouTube. So we are going to repost. So you can, at your leisure, go through, get the information, listen to what Doc said. And remember, Doc said for the month of October, they're having free mammograms. You're going to call Andrews, right, Doc? You're going to call Andrews. He had given the numbers. I'll repost the numbers on the page, so you can, if you can't afford a mammogram, you'll be able to get a mammogram done. Good night. Godspeed. Remember to pray, as Mrs. Ramsay says, and Latoya said, and I said so too. Remember to pray and give God thanks. Gratitude is a must. Yes, we are alive and well and giving God thanks every day. Every day above ground is a good day. And every day you wake up, give God thanks. Over and out. Good night. Thank you, everyone.